for this meeting has begun.
We will open up for questions, and then you can take your phones off mute. If you could just introduce yourself and what hospital you're from prior to asking your question, we would appreciate it. And I'm going to be now turning it over to Dr. Reichwein to talk about the new telestroke triaging process.
Good morning, everybody. It's Ray Reichwein, the LionNet Telestroke Program Director, and I just wanted to highlight a process change that I think will be good for all sites as well as for our personnel to enhance patient care. And it's based on some recent issues and problems that have come up at different sites, and I think we found a way to address this, and your various nurse coordinators have seen the process more recently, and hopefully many of you, the physicians on the other end of the phone line, have at least seen what we're proposing. On the next slide, the reasons for why is what we've seen more recently is the ED physicians and sometimes the hospitalists aren't on the same page as the telestroke consultants as to why the consult went through and or the plan of care, sometimes earlier on, sometimes later on. So the most important thing to us was to make sure the physicians are on the same page and the plan of care is correct. The other thing we've noticed is that the local neurologists and sometimes neurosurgeons aren't even part of the process, and more so for consults that are happening during the day when they're available, and or stroke patients that are presenting roughly a day or so after the onset of their symptoms. Thirdly, I want to emphasize one important part. The process as we've currently set it up as of more recently works very well with nurse-activated process, so I do want to emphasize our goal is to change the existing process, but to put some enhancement on it that will lead to better care. And I will emphasize again that the nursing-activated process is working very well, and we aren't planning to alter that. The third slide highlights one or two things that will be unique, and again, you should have an algorithm in front of you. That's on the fourth slide, and hopefully, all of you can bring that up and just look at that as I talk. So we're going to skip over the third and go to the fourth, which is the algorithm and the process plan. I wanted to walk through that, and then I'll come back to the third slide. Again, the first emphasis point is the current processes that all of the sites are doing as to your identifying a stroke patient. The nursing staff commonly is entering information into the REACH cart to create the starting point will continue as is. So the initial identification of the patient, activating a stroke alert, and putting information in the cart is exactly the same. Also, your initial process in going for a CAT scan and just getting some basic demographic information is exactly the same. The key difference is where the physician comes into play on your end and what we're trying to enhance. And for any stroke patient within last known well 12 hours, on your algorithm, the red diamond box, or the red diamond, so any stroke within 12 hours, less than or equal to 12 hours, to include unknown strokes, wake-up strokes, and or concerns with a significant abnormal CAT scan that warrants an evaluation. You do want to proceed with the telestroke consult just as you've been doing before, so you call our transfer center. They will send a page out for us to sign on to do a telestroke consult. We plan to sign on exactly as we are within 10, no later than 15 minutes of the page for us to sign on. The new step is that we're going to, while we're signing on, interact with the physician on the other end to make sure we're all on the starting page. And the physician on the other end should have seen the patient and is comfortable letting the telestroke consult go through. And we have in the one box what we require of the physician. When the telephone conversation occurs, we kind of want to know just the basic history, the relevant neurological exam findings, the last known well time, Is it worthwhile mixing the TPA? That can be a quick 1-minute discussion between the two physicians. And then lastly, also within that first few minutes, a discussion on their insurance plan and do they need transferred and where. And again, all of that can happen within a few minutes and while our telestroke consultant is signing on. So we still expect in 10 to 15 minutes period, and this will enhance that the two physicians are on the same page. When you make the initial phone call to us to do the telestroke consult, the physician doesn't have to be hanging out there. We just expect that within a few minutes that we can talk to them prior to signing on. And again, hopefully it will enhance the process, and it may expedite mixing of TPA and urgent decision making. The second part is if the patient is not within 12 hours, so let's say they show up within a day of the stroke, more so if it's during working hours, and for the hospitals out there that have local neurologists and or neurosurgeons available, we would like a discussion to occur between the ED staff and or the hospitalist staff and those local physicians first. And if after that discussion the neurologist or the neurosurgeon says, still, let's go through the telestroke process, we are more than happy to do that. But I would like to involve them for more so the non-urgent type stuff directly and have them weigh in on the decision-making. Many times they may be more than available to see the patients and make the decision-making. And again, if they still want to use the telestroke process, one can use the telestroke process. For the sites that don't have any available resources, neurology or neurosurgery, again, we are still available to do any stroke patient for the right reasons.
Press 1 to enter the conference.
So we will not turn down any telestroke consults. That's an emphasis point.
Press 1 to enter the conference.
Try and enhance the interaction between our telestroke consultants and the physicians on the other side, optimize care and optimize resources. The value to the other sites is that we're saving resources on both ends. On your end, as you well know, it takes about 30 minutes to do the actual consult, and it can tie up nursing resources, and that's become a valuable thing more recently. So again, we want to save resources if we can. On our end, if we have several consults to do, again, we have to triage a little differently. But again, the important aspect, if one wants a consult, we're still going to do it, and we are not going to turn any consults away. This is really just to enhance the process as it currently exists. The last thing is, and one more comment. The last thing is when one calls in, it will also allow us to kind of record the original conversations just as a QI process improvement plan down the road to make sure, again, the process is being used correctly. I will stop there for the moment, and I'm sure there will be a bunch of questions and or issues. I also would like to say before I open it up that, again, this is going to be a trial process. There's no one size that fits all, and different sites can do it different or may have different issues. But I want to emphasize before the phone lines open up that we're going to, again, the basic process that we've been using for quite some time will not change. This is just an additional physician step and or involvement of the local neurologist and neurosurgeon step to augment care, and that's what I want to emphasize.